The topic which I am going to discuss today is critical care admissions and discharge criteria in ICU cancer patients. A very important topic. There are some ethical and moral dilemmas with us. We'll try to touch base upon them. To set the tone, I will start with a joke. What is the difference between an intensivist and an oncologist? Please don't take it too hard, the oncologist or the intensivist. The intensivist let you go at the end. Okay. And it was another version of this. What is the difference between intensivist and the bulldog? The bulldog lets you go at the end. So the oncologist come a step after the bulldog. Just on a very light note, don't take it seriously. No disclosures to make, no conflicts of interest. All because I'm an intensivist, so I'll be promoting some ICU advocacy for some of the patients, but you have to make your judgment. The learning points from this presentation will be to understand the need of admission discharge criteria specifically for the oncology setup. Why this particular question arises, we don't discuss this question for pulmonology or cardiology, but we discuss it for oncology. What are the variables affecting these criteria? And then we touch based upon the ICU admission and the discharge criteria. We all know this. The aim of medicine is to cure sometimes, to relieve often, and to comfort always. To prevent premature death, to alleviate suffering, and to practice non abandonment. And we should not abandon our patients in life or in death or when they are not able to take the right decisions. Critical care is not a location, it's a process. It takes place not only in the ICU but everywhere. So, whenever we go on for our outreach for a critical care consult from our oncology or other colleagues, we need to remember this. Some interventions can be done there. For some interventions, patients has to be brought to the ICU. This IHI 2 by 2 matrix tool we always discuss in our mortality cases. What is this? I'll only go to the top horizontal two boxes. Box A, patients who are comfort care only and admitted to ICU. This is obviously the wrong set of patients. You should not be admitting a comfort care patient to the ICU. Comfort care patient, if he is in the ICU, that means your hospital palliative or comfort care services are not up to the mark. Box B, comfort care patients not admitted to ICU but to the ward. What this means? This means your community palliative care services are not up to the mark.
Recording stopped.
Box C and box D I will not discuss because it does not apply very much to the oncology practice. So you should not be admitting a comfort care patient to the ICU for active treatment, and comfort care and palliative care should be provided in the ward or even at home if need arises. So keep this in mind. What is the problem? We have a good lot of oncology patients who come to our ICUs for various indications. But we have to be very, very wise. Who will benefit from ICU care? As the discussion was going on, we are partners in care, and the patients are also going to decide for their loved ones. We are not the only decision makers. Even if it is a metastatic disease with septic shock and the family wants full treatment, we have to provide full treatment. We will explain them, but we are bound to provide full treatment them. Tools capable of preventing up to 40% of all inappropriate admissions, ICU admissions. If you incorporate these admission criteria, you may prevent 37% of inappropriate advanced cancer admissions to the ICU. Non-advanced disease, you admit like any other patient. Presence of advanced directive can help us to make right decisions. Many of these patients are admitted to ICU due to either the malignancy or cancer-related side effects or complications or an underlying medical condition unrelated to cancer. At times, there is diagnostic and clinical dilemma. The physician is not clear. They want a multidisciplinary input and multidisciplinary care. Patient can come to the ICU. Acuity of the disease, high-risk intervention. It could be surgery, it could be chemotherapy, it could be plasmapheresis. Post-procedure care. Always remember this central dogma for patient care. The first step, if it is an acute patient, should be ICU. It should not be ward, then to ICU. First is ICU, then is step down, then is ward, then is home. Do not cut short on these steps unless it is a end of life care patients. Family expectations you have to always keep in mind. Some families or patients will tell you even it is a metastatic disease, keep alive at any cost. You have to abide by it. You have to explain them pros and cons, but you have to abide by it. Some patients will come, help me die. You have to do that. Avoid statistical and medical jargons. 1% chances of survival. If that patient is not that 1%, he is going to die. 99% of survival, but he cannot be that 1% who is going to die. So avoid these statistical and medical jargons. Yesterday TLC was 27,000, now it has become 23,000, patient is improving. Compassionate grounds always have to be used. Quality of life and quality of death also has to be considered. And we should not be prolonging death by our interventions all the time. If we cannot prolong life, we should not prolong death. Sir William Osler. It is much more important to know what sort of a patient has a disease than what sort of a disease a patient has. So always keep in mind. This is one of the comorbidity unless it is an advanced metastatic disease. Oncology patients account for up to 20% of general patients in a general multidisciplinary ICU. More myths than science. We started oncocritical care 2008 or 9 in Max. The dictum in my previous hospital, I'll not like to name that hospital right now, they had a dictum oncology patient should not come to ICU, which was a difficult to digest for me at that time also as a resident. But later on, we opened oncocritical care, medicine ICU, oncosurgical ICU, and now oncocritical care is flourishing. Life-threatening complications occur in 5 to 10% of patients with cancer requiring admission to ICU. So we have to have some degree of ICU advocacy. We need to give them the right science, right outcome measures. Serious illness across advanced cancer no longer means end of life. You have to remember this also, and there's enough data to this. Novel cancer therapies are changing patient outcomes, and they're also creating new diseases which often need acute care. So we need to take a fresh look at various diseases like septic shock, acute respiratory failure. Acute respiratory failure in immunocompromised patient, the outcomes still remain bad because of various reasons we are all aware of. Goals of care have to be clear, and at times even ICU admission should be a time limited trial. And it is time to look beyond the ICU. We need to look and explain to the patient and the family what will be the outcome, say after 6 weeks or 6 months. Then only they can decide better on ICU admission or no admission. Various outcome predictors are used. Dr. Ashutosh also pointed out on some of them. However, an individual patient prognosis is far from perfect, and that employing these criteria requires thorough evaluation of the applicability in the individual patient. These are broad guidelines and it is often difficult to apply it individually. This means and implies that there is still a high degree of uncertainty in ICU admission for oncology patient. Many factors are attributed to this uncertainty, heterogeneity of population, and the most important thing is diverseness in patient approach by different specialties. Most of the times oncologists are less trained in critical care, and most of the critical care setups they are poorly trained in oncology critical care. And the science is also weak in these fields. Most studies on the topics related to oncocritical care are based on patient groups that may not be representative of that particular patient population. Although we are having better results in oncology critical care also, but there are multiple recurrent admissions, variable presentations, and long-term survival is often uncertain, especially if it is a late disease. Although majority of cancer patients would prefer to die at home, and if death is certain, we should die at home only. We should not be dying in unknown territories surrounded by machine and unknown people. The truth is that in US 40% of citizens die in hospital and nearly 60% do so after being admitted to the ICU. So the numbers are bothering. Only a third of patients with serious oncological disease who require ICU admission die while hospitalized. More than half of the survivors show a situation of independence upon hospital discharge. So this is a silver lining in the cloud. The outcomes could be good for almost half of the patient after ICU discharge. Both the excess mortality in 2 well patients later admitted to the ICU, and relatively good survival in two sick patients suggests the need for a broader admission policy because every life matters, oncology or non-oncology, that does not matter. The cancer patients are different, but this does not mean that different measures are taken to restrict their access to ICU. Moreover, because they are cancer patients, they should not have fewer opportunities for admission than other patients. Among the characteristics that should not influence us when deciding on their admission are age, presence of neutropenia, as well as hematological disease with autologous transplant. Always remember, sum is not a number, soon is not a time. If the family or the primary physician is concerned, so we should also be concerned because every life matters. While you advocate ICU admission for a oncology patient, these are the four pillars of assessment: the patient and the characteristic, type and stage of the cancer. If the intensivist is not clear about type and stage and the outcome, they should openly discuss with their oncological colleagues. Reason for admission, another very important parameter, and level of therapeutic effort is the fourth one. Admission policies for oncology patients are based on these four pillars. Always practice non-abandonment. Regardless of family decision or conflicts, do not abandon your patients halfway. If they take end of life decision, I'm not going to do anything. They say, I'm not happy with your care, I want another opinion. Don't abandon those patients. Try to convince them unless they are difficult to manage. Do not abandon them in end of life decisions. Inquiry before advocacy is very, very important. Some families will tell you, do you want us to do everything or just BiPAP or ICU admission or oxygen, whatever? We will do everything. The question is what kind of everything. Everything is a very blanket statement and we should be avoiding such statements. And for every intervention, especially in such critically ill patients, oncology population, we should be asking for each and every advanced ICU intervention before we subject the patients to it. Shared decision making, and always remember patient and family are important in this shared decision making apart from oncologists and intensivists. Early family involvement, early family meeting, multidisciplinary meeting is must for right decisions. Goals of care defined by family and interpreted by us. Always remember the goals of care are defined by them. If they want everything to be done, we have to do everything. And these are dynamic. One day they say, I want to have end of life care. The second day they want to change their opinion, they are free to change their opinion. Do not practice non abandonment in life or in that situation. Another important concept: autonomy is a privilege, it is not a responsibility. Some families are not able to decide because they have never seen such a situation. They might be younger siblings, they might be kids of an elderly people, but they are not mature enough to take such difficult decisions. So you have to be helpful to them and give them the right knowledge and environment to decide on the right decision. Have a balanced approach. The fundamental principle of medical ethics must be balanced and each and every patient individually. Don't say this is a social decision, you have to take this decision. I don't know what you have to do. We generally do that. Well, what you have to answer is, well, if I were in your position, I think I will do this. Do not say, this is not a medical decision, this is a social decision, you decide. They are not able to decide, that is why they are coming to you. There are no tight compartments. Palliative care teams should be involved in ICU practice, especially for oncology. Oncologists should be involved. Intensivists can be involved in outreach in the hospital or at home also at times. Concordance between intensivists and oncologists is must for the right decision. They should be collaborating, especially for some differentiating characters in oncology patient. So there is a huge need for precise criteria, but we will have, can we have very well defined criteria which we can apply in every patient without any gray zones? The answer is no. So what we need to have clear admission criteria for whatever evidence we have as of now. Development of new admission policies that expand the classic dichotomous view of whether or not they are correct candidates for admission to ICU. They analyze the best treatment for them, avoiding excessive treatment and above all respecting the principle of their autonomy. So we have to break this dichotomy, yes or no. It is a gray zone and let it be gray zone and decide on each day. The following critical ill patients should not be admitted to ICU. First, we should understand who should not be admitted to ICU. Patients or next of kin informed refusal to admit to ICU. Any disease with a treatment limitation gap plan, anyone with a living will or advance directive against ICU care, terminally ill patient with a medical judgment of futility, low priority criteria in cases of pandemic or disaster situation. This is a big no. So, which patient should be admitted? If they have agreed for full code management, yes. If the family and the physician wants ICU trial, yes. If they say no ICU admission, no ICU admission. There are some specific ICU admission situations for oncology patient. Prophylactic admission, a patient who is expected to go into organ dysfunction, say CAR T cell therapy, you can admit them.
Recording in
Exceptional
progress.
admission, a patient with high mediastinal pressure because of tumor, they are giving some steroids or radiation to decrease the pressure. They can be admitted to ICU or palliative care. Although we say palliative or end of life care should not be admitted, but you have to look at your logistics. Smaller setups, non-oncology setups, they might not be well geared up logistically to give end of life care in the wards. So if you have facility, again, this is not a big no. This is a flow chart, same things what we have discussed. This is from Annals of Hematology 2018, consensus statement for cancer patients requiring intensive care support. Whom to admit to ICU? Full code ICU management without limitations of ICU resource should be offered for ICU patients if long-term survival may be compatible with general prognosis of the underlying malignancy. This is A2U recommendation. U means uncontrolled trials. Whom to admit again? Patient with poor performance status, not eligible for further anti-cancer therapy, dying patient, as well as those rejecting ICU treatment should not be admitted to the ICU in general. For patients not fulfilling the above described criteria for full code management or ICU refusal, time limited ICU trials or predefined do not escalate decisions like do not intubate, do an AR may be adequate options. This is B2U recommendation. When to admit to ICU indications and screening for organ dysfunction, cancer patients should be considered for ICU admission in case of manifest or incipient acute organ dysfunction, A2U recommendation. Centers should establish local admission criteria for critically ill cancer patients, as well as standardized admission procedures such as joint assessment by cancer specialists and intensivists, if available, A3 recommendation. Next is ICU discharge. Discharge from ICU of almost 2 million patients found that of every 100 patients discharged alive from ICU, between 4 and 6 are readmitted and 3 to 7 die before being discharged again from the hospital. This is from Critical Care 2014, which was a meta-analysis by Turin Group. So you have to consider not only discharge from the ICU to ward, but life after ICU discharge. Also, you need to consider what will be the long-term outcomes. ICU discharge rarely can be directly to home, very rare. It could be to a step-down unit, ideally, HDU or whatever step-down unit you call it. It could be to the floor, majority of patients. It could be terminal discharge, the patient is going to home to die. It could be allow natural death in the ICU itself. And we all practice it variably in various centers. So this is what we call about terminal discharge. You matter because you are you, and you matter to the end of your life. We will do all we can not only to help you die peacefully, but also to live until you die. Always remember, quality of life and quality of death are basic rights for the patient and for the family. This family should not live with any guilt after the demise of the near ones. ICU discharge criteria, I'll be very brief now. Discharge patients when they are stable, common sense. Discharge patients at a lower level of acute care, depending on patient disposition, prognosis, stability, or the need for patient interventions. Generally, widely, almost all hospital ward care is suboptimal. So it is better to shift to a step down unit rather than directly shifting to the ward. And it's a burning platform. And most of these patients, if they are really not very stable, they will come back to ICU and gives a bad taste for the family and for us also. Have a critical care transition program. Visit these patients in the ward every second day, third day, depending on the seriousness. Have a proper handover and reconciliation form between physicians also. There is a good reconciliation and handover form between MOs, between nurses, but we do not hand over to each other, which is not right. ICU discharge criteria: return of physiological aberrations to near normal baseline status, reasonable resolution and stability of acute illness. Patient family agrees for ICU discharge for a treatment limiting decision or palliative care based on lack of benefit from aggressive care. Should be a medical decision, not obligating family agreement, and as far as possible should not be based on economic constraints. So if you think the family agrees there is no benefit from aggressive care, you have to have a mutual decision. For infection control reasons, with ensuring appropriate care of the given patient in a non-ICU location, very difficult to apply in Indian setups, but we do at rare occasions. If you have to rationing of the resources, prioritization in face of resource crunch, what we did in COVID, and at times you have to practice this. Time limited trials of intensive care for critical ill patient with cancer. How long is long enough? This is from JAMA Oncology 2016. Time limited trials of intensive care for critically ill cancer patients. Trials of ICU care lasting 1 to 4 days may be sufficient in patients with poor prognosis, solid tumors, whereas patients with hematological malignant neoplasm or less severe illness seem to benefit from longer trials of intensive care, as was discussed in the discussion also. Lastly, you need to open the doors of ICU to the family and to the patients. You have nothing to hide, and we should feel proud of how we care. If you face uncertain situations, no prior consent for or against ICU admission, err on the side of caution, you admit, then you decide later on after 24 hours, after 12 hours, or in the next morning. We need to create memories to cherish in life and in death. Why I'm telling this sentence? Many of our Neti colleagues are also here. When we shifted to Neti, I met at least 5, 6 doctors and other administrators also. And most of their parents were admitted at Max Cancer Center, and they were there for end of life care. And they still have good memories about the death of their near ones in the hospital setting. So create memories to cherish in life or in death. Simplified take-home points: access to ICU on the basis of established criteria with careful consideration on the long-term prognosis, reassess and discuss with patient, physicians, next of kin if legal representative is there. If in doubt, give ICU trial. Admission to ICU can be emergency. Discharge from ICU can never be an emergency discharge when everyone is comfortable. Have critical care transition programs. Interdisciplinary communication is must. Life support may be withdrawn, but care is never withdrawn at end of life. Thank you. Questions?
Thank you, Dr. Zaveri, for
Thank
your
you, sir.
insightful presentation.